All right, y'all. Have you ever heard this saying that you can sell poo? All right, y'all. There were changes this year in ACLS, so we're just going to talk a little bit about the changes. There weren't major changes in ACLS, so she hands this to me. If any of you ever went to ACLS, where I have been, I don't do this very well. I can save your life, but I can't run a remote. I can't at home either. The kids are like, hand that to me. If I can get it away from my husband, start with. So there were some changes in ACLS. Not real major ones, but a few that are important to know. So we're just going to kind of go over. I was just going to do the changes, but then after I put the changes on, I only had 2 slides. I was like, well, that's not very entertaining. So I've added some review to it also. BLS. The big thing with ACLS now is they said we weren't doing CPR correctly. So if we're not doing CPR correctly, guess what? If you don't do CPR correctly, you can't really go any further, can you? So, and if y'all have taken ACLS, you'll know when you come in, you have to check off for CPR, don't you? Every time somebody says, why do I have to take CPR? Well, because this is not a full course, you're just checking off. But, so BLS is real important. They're really, really pushing it. There's a few things that might sound new to you, and then there's some things that you're like, oh, I already knew that. But just to reiterate to you. Big thing is they want you to allow chest recoil. Now, if you're doing chest compressions and you're on there and you're doing 100 a minute and you're just going away, guess what? How much blood do you think gets in that heart? Probably not much at all. Well, if there's not much in there, what's going out to the body? None. So even though we are going to go fast and we want at least 100 beats a minute, we do want to do it where we fully come up off the chest and allow the blood to flow into the heart, so when we push again, and if you ever take class with me, I don't have all the $20 words. I don't use a lot of medical terms either. When you smash the blood out of the heart, it goes to the toe again, okay? So that is what the big push about that is. They really want you to allow chest recoil. They want at least 100 beats a minute, at least, okay? This is really horrible, but while you're doing chest compressions, in your head, everything's a song to me. In your head, do not do it out loud. Yeah, you know what Monica said. I know she's going to say. Actually, I do another one bites the dust. We'll get you there. Do not sing it, especially if there's family there, okay? That's not good, because families will get offended, okay? But another one bites the dust will get you 100 beats a minute. Now, I don't know when you get to the bridge of the song. I don't know about that, but, you might not get full recoil right there. Big thing is American Heart likes Petco's and capnography. Well, the first time I looked at that, I thought, what is that? We don't use that. Guess what? Not a lot of people do use it yet. But somebody on the board of American Heart Association must have stock in Petco and capnography. That's their new push. They like the Petco, and it's a waveform. It's kind of like an O2 sat waveform, and I guess that's the best way to put it. Like an O2 sat, but instead of being an oxygen saturation, it's your CO2 carbon dioxide put out. If you have a reading of 10 or better, you are doing really good chest compressions, and that's what we want. So if the person doesn't have a pulse, you'll want a Petco reading of 10 or better. I didn't put it on here, but if the person has their own pulse, you would like their capnography reading to be 35 to 40. And that means that they're having good perfusion and stuff. They also use that when, it might be on the oxygen slide, they also use that when somebody's intubated to see if they're oxygenating well. Another thing is they don't want any chest interruptions to chest compressions more than 10 seconds. 10 seconds is not very long, is it? So, when you are defibrillating somebody, you put the little pads on and you are charging the machine. Now, it doesn't take our Zol very long to charge. But on the videos that they show you for CPR, for ACLs and stuff like that, they are doing chest compressions in between the charging of the machine. Because they have all these graphs for you. I'm not into graphs either. All these graphs, it takes a couple of beats to get it up here, blah, 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 then it falls, blah. I can't do all that. More than 10 seconds off the chest decreases your getting them back. Okay? So no more chest compressions interruptions more than 10 seconds. Capnography allows for good quality monitoring of CPR. Switch compressors every 2 minutes. Now this is something we've been talking about for years, but they're really pushing it. All right. The reason is we have a couple people in ICU who love to do chest compressions, and they get up there and they are doing some good chest compressions. I don't know about Joe. Hey, you want to jump up there? You ride that pony. I'll stand back here and chart. My favorite thing. But it is really hard to do chest compressions. After about 2 minutes, you need to come up off the chest because you are not pushing 100 times a minute no more, and you're not pushing deep enough. Okay. With that said, compressions now are 2 inches on every adult. If you're doing chest compressions on me, you might want to go a little further than 2. Brittany Jordan, you wouldn't want to go more than 2 because you might pull out a vertebrae when you come up, Me, you might do a little deeper, but at least 2 inches on every adult. And that's just the things with CPR. We still do CPR stuff in ACLS. When you take the test for ACLS, there's 50 questions now. At least half of them are CPR questions. That's how important ACLS or American Heart thinks BLS is for ACLS. Any questions about BLS? Oh, Tara says to remind y'all that RSOLs show us how people are doing compressions. Use that little purple box. After about 5 or 6 compressions, the purple box will be full. If you're going too fast, guess what? The purple box don't fill up because you don't get full chest recoil. So our Zols will tell us. If you go to Fayette, they don't have the new Zols, and it doesn't tell you. So we have a lot of people that come over from Fayette to take ACLS with us. I'll be like, oh, our Zols, oh, yours don't do that, I'm sorry. You only get a couple of things at this hospital to brag about. And I brag about the Zols. It will tell me if I'm doing CPR correctly or not, because if you're not, it will say that you're not doing it adequately. If you're going too fast, it'll tell you you're too fast. So that's a real good part of that. American Heart's made some changes with oxygen. My thoughts, and when I teach ACLS, I tell everybody, if they're having a coronary event, you put them on oxygen. Everybody now. Okay? Guess what? American Heart decided they didn't like that. They said that you're actually causing more harm putting oxygen on everybody. So their guideline now is only if the stat is less than 94. Like, I don't know about that. You have clots sitting in your heart, a little more oxygen on this side of the blood, gets a little more on that side, but they say 94% or higher is adequate, so you don't put oxygen on somebody. There's your capnography. It's the most reliable method of performing and monitoring correct ET2 placement. Hopefully, at the new hospital, we'll be able to do that. I think we will. I think our monitors will be able to do that. So that'll be anybody who's on the ventilator will do that. If the patient's not breathing, but they have a pulse, you're going to do rescue breathing, aren't you? So what you're going to do is ventilate them once every 5 to 6 seconds, which ends up being, I got 8 to 10 breaths, but it should be 10 to 12. All right, just to make sure you're awake, scratch out 8 to 10 and put 10 to 12. All right. This was last night. I was trying to get these slides together for y'all today. So, and then remember, when you get an ET tube in place, you don't have to pause for compressions. You just do your rescue breaths, or you're breathing every 10 times a minute, which is what, about every 6 to 8 seconds. Okay. And remember, when we suction people with ET tubes, that we only suction on the way out. And American Heart likes to standardize everything, hence the 30 and 2 thing for everybody. We don't suction more than 10 seconds. And it's only on the way out. Never on the way in. You don't want to pull something down with you. Just want to take it out. Okay? Any questions about oxygen? one's not really anything new for American Heart. Big thing is that, you know how we have the push for people, for all the lay people, if you have chest pain, take an aspirin. And I'm going to tell you, most Americans are on board with that. I have chest pain, I got to find some aspirin. And they do it. American Heart now, have you noticed the commercials? If you have atrial fib, you could be at risk for a stroke. Okay. Guess what they're pushing out now? Stroke. All right, so the stroke awareness is coming out to the lay people. So I just wanted to include it here just to kind of make sure you understand. We're going to be seeing strokes out here for people now. The big thing is you need a head CT of the head, a non-contrast one, to see what type of CVA you're having. 78% of strokes are ischemic, and that's good. If you get some place and you can get a CT of your head and it doesn't show a bleed and you get TPA, and you may be able to use the right side of your body for the rest of your life. You know, I don't know about you, but it takes both sides of my body to walk somewhere. You know, so it's a real good push for people to know that. So you do want people who are having strokes to be aware, oh, I might be having a stroke, get to a hospital so they can get treated. EMS transport. I don't know about y'all, but my family, when I was growing up, is really poor. My family members think I'm rich. I'm not rich. By any means. I always got told, can't call the ambulance because it costs too much. But yeah, it does. When I worked at Vital Care, it's $400 when I came to your house. If I toted you someplace, it was $400 plus every mile that we drove, plus anything I did to you. So it is expensive. I also got told, well, we can get to the hospital before the ambulance can get us there. Yeah, true. Even when you're a kid, you don't know these kind of things, but now as an adult, I think to myself, oh, you people are stupid. It's hard to do CPR in the back of an ambulance at 70 miles an hour when somebody else is driving the vehicle. But it'd be really hard to drive 70 miles an hour and do CPR at the same time. You know, so it does help to get EMS involved. They will do an O2 sat, see if they need some oxygen. They'll put them on the monitor. They'll get a glucose, because guess what? The person could not be having a stroke. They could just have hypoglycemia. You know, we don't do real well educating our patients. My mother's diabetic. She got hypoglycemic about 6 or 7 years ago. My daughter was with her. My daughter was like, Grandma was acting weird today, Mom. Well, what was Grandma doing? She was just acting like she was confused and sweating and. Ew. Did you check Grandma's blood sugar? No. Mom was hypoglycemic. Hello, no wonder she was acting weird. She probably was acting like she was having a stroke. But so EMS transport is very essential, and people need to be taught. Call the ambulance. Only 35% of people pay their ambulance bills. Trust me. Just call people at Vital Care. They'll tell you there's no money in EMS. That's why they don't get paid anything. Alrighty, there is a new study for American Heart. Now this it has not been FDA approved yet. Okay, and they'll tell you in their film that you watch that it's not been FDA approved. It's been 3 hours, 3 hours from onset of time that you're normal. So if you saw Grandma last night at 8 o'clock and you call Grandma today and she doesn't answer the phone, it's 11:30 and you go to her house and Grandma's had a stroke, she would be way out that 3 hour window, wouldn't she? If you talk to Grandma at 9 o'clock this morning and she was fine, and you can't get her answer and you go right now, she's still 2.5 hours, so she's still within that 3 hour window. American Heart is talking about, for a select number of people, extending that to 4.5 hours. So they have approved it, but the FDA has not approved it yet. So that is something that probably is going to evolve. All right, pre-hospital, Cincinnati pre-hospital stroke scale. Do we all know what that one is? Smile. If you take an ACLS, you see the picture of the guy whose face is up, one side, one's down, the arm drift thing. And then, how many of you would think I was having a stroke? I usually can't say, you can't teach an old dog new tricks. We all know Karol Meredith opens her mouth and out comes something. She's like, what did I just say? But that is the stroke scale that people use. They say if you fail one of those sections, you have a 75% chance of your stroking out. So that's their big thing is that one too. Any questions on CPA? Are y'all awake? Okay. It's almost lunchtime. All right. Nothing really new with meds, okay? They're the same old meds, same dosing, except we don't give atropine no more for PEA or systole. PEA or systole. Oh, we give some epi. 3 to 5 minutes. Oh, I'll give some more epi. That's about all you do. The big thing with PEA and systole is you got to figure out why they're in it. So you have to do those probable causes, the H's and the T's, go down through all those things. So that's the only real big one. So we only give 0.5 if somebody is symptomatic with bradycardia. Okay? So that's the only time you're going to give atropine. So no more atropine if somebody's PEA or systole. Adenosine. What's the dose of adenosine? All right, y'all, it's right there on the board. You can cheat. It's right there. It's 6, 12, 12. We give it IV slam and you flush behind it. Okay, you push it in as fast as you can give it. At least AC or higher. If you go through the hand, by the time it gets up to the shoulder and to the heart, guess what? You ain't gonna see anything. You know how you see that flat line? You almost poo your pants. Please come back, and they come back. None of that. You just truck right along. No problems for you. Oh, it didn't work. No, it didn't work because you didn't put it in the right place. It has to be at least AC or higher really for it to work. And you really have to flush behind it really fast. So I like to call it IV slam. Amiodarone. Dosing of amiodarone, 300 if they're dead, meaning they're pulseless. So if they're VFib or VTAC with no pulse, that's pretty dead to me. You give them 300. If they have a pulse, VTAC with a pulse, what about VFib with a pulse? Can you ever have VFib with a pulse? That's a trick question, y'all. If somebody calls you and says, hey, so-and-so's on the VFib and you go in the room, they're brushing their teeth, they're not in VFib. Okay, they got a lead flopping someplace. But if they're half dead, I always say you give them half a dose. So you give them 150. And you give it slow. When they're dead, you give it fast. When they're half dead, you give it slow. Okay, so you're going to give it over about 10, 15 minutes. And then hang a drip. All right. You can convert amiodarone drips. Will get converted over to PO amiodarone. Talk about atropine, dopamine. Never had to know dopamine doses before for ACLS. Guess what? You do now. Test question, big as a date. Dose of dopamine. So they like 2 to 10 mics per kilogram per minute. Remember, dopamine is weight-based. All right. Levophed is not. Dopamine is. So always weight-based. And we give it because we want a systolic pressure of at least 90. What's another instance that you would give dopamine to somebody? Bradycardia. Okay. If you give dopamine to somebody who is bradycardic, it's going to raise their blood pressure because you're not going to give it to them unless they're symptomatic anyway, right? What's the big thing that makes you symptomatic with any kind of arrhythmia? When you lose your blood pressure, right? So guess what? Blood pressure is going to go up with dopamine, and heart rate's going to go up with dopamine. Make sure your patient has enough volume on board, though. Because if you give dopamine to somebody who doesn't have enough volume, oh, you'll be sad. Because that heart rate will be 150, 160.
Heart rate went to 183.
So if they're not volumized, you might want to choose an epi drip instead. All right, for the symptomatic bradycardia. And then epinephrine. Everybody who takes ACLS needs to know the dose of epinephrine. I'm just going to tell you. You should know it by the back of your hand. 1 milligram IV every 3 to 5 minutes. No ceiling dose, which means that you can give 755 of them if you want to. Now, as long as it's an increment of 3 to 5 minutes. Okay? So if your coatings are made for 12 hours, you might give 750 of them. Hopefully you wouldn't coat somebody that long. But epi has no ceiling dose. All right? But that dose needs to be something that's in your head, because guess what med is given to every patient who has no pulse? It doesn't matter if they're PEA, doesn't matter if they're systolic, doesn't matter if they're VFib or VTAC, does it? If they are pulseless, the first drug you're going to give them, besides oxygen, is 1 milligram of epi. So if you are in a code on the floor and you're like, I don't know what to do. If they have no pulse, you can't go wrong with epi. And what is the dose? 1 milligram every 3 to 5 minutes. So that is a drug that you should know. And they make it really good really easy for you, because when you get the box of epi out, guess how much is in that box? 1 milligram. So that's pretty good. All right. So those are the meds that you really have to know for ACLS. The only thing is, just remember, atropine has fallen by the wayside. We don't really give it for PA assistance anymore. All right. Who knows what ROS means? Besides Dana and Brittany. Does anybody know what ROS means? Return of spontaneous circulation. It means that you have coded this person who didn't have a pulse, and guess what? You were successful because they got a pulse back. Yahoo! Well, maybe Yahoo. Hopefully they have a brain. You never know. Recommended dose of fluid bolus for somebody who's went through an arrest in his back. They want you. Now, how much do we give normally? 500 to 1,000, don't we? So on the test question, I said 500. That's what we always give. I was wrong. You said I was wrong. They say you give 1 to 2 liters. So they like a lot of fluid. We talked about this before. You want a systolic pressure of at least 90. If you don't have that, you may have to use a vasopressor to achieve that blood pressure. And your dopamine dosing, if you use it, is 2 to 10 mics per kilogram per minute. Big thing, somebody who has survived a code, has got a pulse back, they're not breathing, they're not responsive. Studies have shown for 24 hours, if you cool them off and do hypothermic therapy on them, that they have a better neuro outcome. What did I just say before? You got a pulse back, yay! Oh, it may not be good if they don't have a brain. So this will help preserve the brain for them. You know, if you save a piece of ochre and there it is, all you've done is made the family, somebody go see at the nursing home for 6 months, 7 years, you know what I mean? So we want to preserve the brain, and they say by hypothermia that'll do it. Now, if the person is responsive, do not do that to them, okay? They'll know they're cold if you do it and they're awake. So that's what we want to do. Those are really the big changes. There's a algorithm now for post-arrest. This is the algorithm for post-arrest. It would include, if you thought the person had an MI, getting them to a cath lab or doing thrombolytics if they need that. It would include doing your antiarrhythmic drip, you know, amiodarone if you gave that and it converted them, those kind of things. So that is a new kick to ACLS. When you take it, you know, everybody, when you took ACLS, somebody in the group had somebody who died. You know, you always felt like you were the hero. Oh, my patient died. Somebody had to have a patient die, because you have to talk about the circle of life, and you know, we all come and go. Hopefully we do it after we've been here a long time, but not always. We don't always live a long time and then die, do we? So that's how you kind of drug that into ACLS when you did it. Now when you take ACLS, everybody survives because your instructor has to make you go through the ROS algorithm. All right? Do y'all have any questions? Y'all look so lively. All righty. If you don't have questions, Daniel liked this right here. I'd probably be dead for 24 hours a day because I don't exercise very much. I got upset when they moved my office to Guam. And I have to walk. They're forcing me to exercise at least twice a day, because twice a day I have to walk from the parking lot all the way over to Guam. And if I'm lucky, I only have to do it twice a day. Somebody over here makes me usually do it more than twice a day. I won't talk about that person though, because they're here. I'll wait till she's not here. So since y'all don't have questions for me, I have questions for you. We were going to play a game of Jeopardy, but I did not have 36 hours in the day yesterday. I still had 24. So I was forced to not do the Jeopardy for y'all, but I was looking forward to it. And if I could have done it in my, if you could have got into my mind, we could have done Jeopardy, but you might not want to get in my mind either. What's the dose of EpiIV? Every 3 to 5 minutes. What's the ceiling dose? Not a ceiling dose. All right. What is the, what reading, Petco, indicates an adequate chest, that you're doing adequate chest compressions? 10. You want at least 10. So if you had a Petco reading of 7, what would you think you need to do? Change your person who's doing compressions maybe, or just tell that person that's doing them, hey, you need to speed up a little, go a little deeper. All right. Describe how you would perform the Cincinnati pre-hospital stroke scale screening. I wish I could stand up here. You know what it sounds like? Charlie Brown teacher. Because none of y'all talk loud enough. So it just sounds like. Ask them to smile. What do you want when they smile? Both sides of them go up. You want them to be symmetrical. If you want to use the fancy word that I usually don't use. What do you do with their arms? What do you ask them to do with their arms? Okay. Hold them out. And the big thing is you do it with your eyes closed. So you want their hands to be out, not to fall down and things like that. And what do you want them to say? Can't teach an old dog new tricks. Yeah. All right. Had to think about it. I'm telling you, my brain is not good. All these people who think I have a good brain are sad. I do not have a good brain. All right, how much fluid do we give for a person with who's gotten their pulse back? 1 to 2 liters. Okay. Oh, look, I didn't finish my question. I was going to ask Tara, what do I put? I can't put what does ROSC mean. What other word do I want? I guess I forgot. I know it stands for return of spontaneous circulation, but what does it really mean? It means they have a pulse. Okay. For what condition would you advise the patient to perform a vagal maneuver? Now, we didn't talk about this one. I threw one in here too. So, SVT. Okay. Especially if it's regular and it's narrow. Because if it's narrow, if the QRS, and when I say narrow, I mean the QRS is narrow. If the QRS is narrow, it means that somewhere above the ventricles, the heart got excited and it's just caught in that re-entry, and it just keeps going to it. And if you have them cough, bear down like they're having a bowel movement. And one big thing that's really good is if you get a straw and you bend it backwards and you put a rubber band around it, have them blow into a straw. That will do the same thing. And a lot of times just doing that will cause the heart to slow down and go back to its normal rhythm. Describe how adenosine should be given.
Slam.
Slam it in and make sure you flush behind it. All right. Also, remember when you give adenosine, when we defibrillate somebody, what do we do when we defibrillate somebody? I know we put the paddle on, we shock them, but what do you really do?
Stop the heart.
Okay. What you're doing is you're putting jewels in the heart and you just totally wipe everything out of the heart. Because what's happening is the bottom of the heart is just quivering, right? When we defibrillate. When we synchronize cardioversion, it may not be that the bottom of the heart's quivering, but we just introduce some jewels to it. What we want to do is totally, like you said, knock the heart out. We want the heart to totally stop, and then we want it to take its, the SA node to kick back over and take back over, right? Well, when you do adenosine, you know, you're tacking along and then you have that straight line, and you are having a little panic attack, but the patient's not, because they're flatline, aren't they? What you're doing is you're chemically inducing a defibrillation to them. You are knocking the heart out so the SA node takes back over, hopefully. All right? So it's very scary when you see it. All right. What type of patient would you give hypothermia treatment to? Somebody who's ROS, who got ROS, but what?
Unresponsive.
Unresponsive, so make sure they're unresponsive. All right, what's the normal dose of dopamine?
2 to 10.
2 to 10 mics per kilogram per minute. What kind of patients? There's 2 kinds of patients that we are, well, there's more than that, but 2 kinds of patients we talked about today that you're going to give them to. Somebody who's bradycardic that atropine didn't work on, and then somebody whose blood pressure is less than, systolic is less than 90, with enough volume on board. All right. So don't go giving somebody's bleeding out. Don't go give them a bunch of dopamine if they're bleeding all over the place, because that'll cause worse troubles. All right, what's the recommended depth of chest compressions? 2. That's a change because we only used to do 1.5 to 2. Now they're saying at least 2. Okay. All right, we didn't talk about this one, but you should know this. What rhythms on the monitor can be PEA?
Anything.
There's 3 rhythms it cannot be. It cannot be V-fib, cannot be V-tach, and cannot be asystole. Can you tell me why?
Because there's not going to be a pulse for them.
Right. It's pulseless, and when you have somebody who's pulseless, you only have 2 choices, don't you? If you're looking at an ACLS algorithm. Somebody doesn't have a pulse, you put them on the monitor, you're going to have one of 2 things. You're either going to have PEA systole, or you're going to have V-fib or V-tach without a pulse. So PEA asystole can't be asystole, and it can't be V-fib or V-tach. Because we think about it, do you treat asystole totally different than you do V-fib, V-tach? What do we do for asystole? We only give atropine, or we only give epinephrine, and do our H's and T's, right? That's not a whole lot, is it? It makes for a very long time if you're standing there giving atropine just every 3 to 5 minutes. But if somebody's in V-fib, V-tach, what do? We do a lot more than just that, don't we? We do give them epi. We shock them, we give them epi, we circulate CPR on, of course you use CPR for asystole and PEA. We circulate it, we look again, do we need to shock again, we give an antiarrhythmic, So you're doing a lot more for V-fib, V-tach than you are for asystole PEA. Unfortunately, we used to call asystole a confirmation of death. We don't do that in ACLS no more because I want everybody to survive, but it truly is a confirmation of death. How often do the chest compressors need to switch in BLS?
2 minutes.
2 minutes. What if the person says, no, I'm good, I want to keep on doing chest compressions?
You can do it anyway.
Get off the chest. You can come back in 2 minutes. Move. All right. What is the recommended rate of chest compressions? At least 100. All right, here's one for you. Now you do this with CPR, and we do it with ACLS too, because we check you off for CPR with the AED. And there's questions on the test about AED. Okay. So tell me, what do you do? How do you put the AED on? The very first thing, and it's the hardest thing for a nurse to do, is to open the pack up and turn it on. We want to open the pack up and start doing things. No. Open the pack up and on. It tells you what to do. Because listen, I've listened to some AEDs. It will say, apply pads to patient's bare chest. And when you apply them, plug in pads next to flashing lights, and you plug it in. And then it tells you, analyzing rhythm. Stand back from patient. Do not touch the patient. And guess what? You can do CPR any other time except when it tells you it's analyzing. Okay? Because an AED is only going to shock, or tell you to shock, V-fib or V-tach. Right? When we first got AEDs, I was trying to be smart and say, well, what if the person's in V-tach if they have a pulse? It's going to tell me to shock them. My instructor looked at me and said, well, you shouldn't put it on somebody who has a pulse, should you? I guess not. That wasn't the right answer. So, if you have a pulse, don't put the AED on. It only shocks V-fib or V-tach. So, and it takes it a while to analyze it. The reason being, it's a machine. Number one, if you've ever been around a tele-monitor, it will alarm at you and tell you people have V-tach. And you'll be like, oh God, the person have V-tach. The person had no V-tach. They just moved around a little bit. Okay, so it's going to take enough time to make sure that person's in V-fib or V-tach. It's not just artifact that it's seen. And then it'll tell you if a shock is advised or not. So that's how you do it. The biggest thing with an AED is you open up the pack and you hit on. And you listen to it to tell you what to do. You don't start doing things on your own. And if you're standing there with a dead person, it takes forever. You'll be like, hurry up. But that's the way it is. So let's say we are on AEDs now. If you're using an AED, I find somebody who's pulseless and I put the AED on, and it tells me apply pads to patient's bare chest. I do, and I plug it in, and it just keeps saying, plug-in pads connected next to flashing light. It just keeps saying it over and over. It never tells me it's going to analyze. What would you do? What would your next action be? Start doing compressions because something's wrong with the machine. Okay, so you just go on and do your compressions. Likewise, when you're talking BLS, they have primary surveys and secondary surveys in CPR. Also, if anybody's in EMS, EMS is taught primary surveys and secondary surveys. We don't do primary and secondary surveys as nurses because we're pretty safe here, aren't we? I mean, I don't have to walk into room 6 of ICU and look and see if there's a shooter out there that's going to get me, or look and see if there's an electrical line down or something like that. But EMS people have to do that because you're out in the real world. You never know who's hanging around the corner. So their primary survey is always they glove up first. PPE is my scene safe. So BLS has introduced that kind of to their way of thinking. Their primary survey is anything that a layperson can do. What do lay people do? They do chest compressions, they open airways, they do breathing, and they defibrillate, don't they? If they have an AED, they can defibrillate. So those are things that you can think about because lay people are taught how to use the defibrillator, and it is defibrillating. It's not, they don't carry around a Zoll, put the pads on and do it that way, and have to diagnose it, but they can defibrillate with an AED. So that's AED pretty much that they talk about. Tell me about amiodarone. What's your dosing of amiodarone?
300 if they're dead, 150 if they're half dead. Then start a drip at 1 milligram per minute for 6 hours, and then down to 0.5
Can you tell me what
milligrams per
ICU
minute,
nurses are?
which is 16.6
I know my
cc's per
amiodarone.
hour.
Yeah, she's continuing on. 300 milligrams IV push if they're pulseless. If they have a pulse, we do 150 over about 10 or 15 minutes. That's called bolusing them. Then you hang a drip for 1 minute. Just remember though, if you do an amiodarone drip, it only runs at 1 milligram a minute for 6 hours. So if you hang an amiodarone drip on 3rd floor because the person went into VTAC, they shocked them, and you had to wait a minute for them to get a patient out so you can get one in, don't be upset when the ICU nurse calls you and say, hey, when did you start the amiodarone drip? And if she forgets and calls you back again, it's just because she's old and senile like I am. She might have to ask you again. The reason is because she can only run that drip at that 1 milligram a minute for those 6 hours. Then for the next 18 hours, she's going to run it at half that dose. So that's the reason why she needs to know. We might seem a little heady to people who work the floor because we want to know every detail there is. I'm sorry, that's just ICU nurses. If Dana goes in my room and comes out of my room while I've gone to the bathroom and I say, come out, I'm like, what are you doing in my room? It's just the nature of the beast. We have to be like that. We can't help ourselves. Alrighty. Why do the alarms have to be so annoying? I wonder what it would be like if there were songs in place of alarms. I would be in heaven. Except I probably would be like this, wait! Don't hook him back to the bed. The song is getting to the good part. You know? Yeah, maybe we should just leave them where they are. Any questions about ACLS updates? Review.
What is ACLS?
Here is January. Well, actually, we have, if your card is in date, you can do it on Halloween. We're doing renewal Halloween here, which means you come in, we watch a couple videos, you check CPR off, you check off airway, you do a mega code, take the written test, you go home. So it's no teaching. Somehow there always gets some kind of teaching in there. I can't help myself, but it's a half a day. So yeah, it's pretty frequently that we do the renewal courses too. All right, if there's no questions, it's lunchtime. Let's be back at 1. Is there anything else we need to